on to Workplace, please email me and I'll be happy to send you a copy of the recording. While our presenter is speaking, we will have the lines muted to reduce unnecessary noise, but we will unmute at the end of the presentation for questions and comments. I do encourage you, though, to enter your questions in the chat box throughout the presentation, so we'll be ready to talk when the time is allowed. Now I'm going to turn it over to Dr. Lisa Letourneau, who will be our moderator for this session. Lisa?
Hi, Kelly. Hi, Kelly. Thanks so much. You hearing me okay?
Yep.
Great. Super. Thanks so much, Kelly, and everybody joining today. I'm pleased today to welcome everyone to the call and to our speaker, Dr. Chris Kolker. Dr. Kolker is a board-certified physician in family medicine, hospice, and palliative care, and works with the United Community and Family Services in Connecticut. UCFS, United Community and Family Services, is a nonprofit community health center offering services to the insured, uninsured, and underinsured for over 130 years. Dr. Kolker completed his medical training at the University of Oklahoma Medical School and his residency at the St. Anthony Hospital in Oklahoma City. So we are very pleased to welcome Dr. Kolker to talk about his experience using Choosing Wisely in a federally qualified health center and his role serving as a physician champion. So, Chris.
Yeah. All right. Thank you very much for that warm introduction. This is something that I very much enjoy talking about because this really is one of those things that truly has changed how we do business here, how we see patients here, how we provide care. It's all about the mindset, and this was a wonderful program to change that mindset. All right, let's get to this first slide. Now, when we first started, I'll be the first to admit, I had heard of Choosing Wisely. I think it was in one of my journals somewhere. I couldn't tell you which journal it was. I wasn't quite sure what it was about. I didn't know if it was one of those things that's going to go away on its own really soon, and I didn't think much of it. And so in a lot of medical practices, unfortunately, that especially the word is out there better now, but I'll be honest with you, 4 or 5 years ago, I think that would have been the norm. We certainly weren't sure of its origin, and we certainly were unsure of its significance if it was going to matter. As for a lot of people who've been around a while, I would love to say I'm right out of residency. I am not. We've seen a lot of programs come and go. Maybe this was just going to be another one as well. And that's kind of the attitude that I think I had when this first started and that a lot of other people had as well. So the awareness was a little bit there, but not that much. And that was about, golly, 3 to 4 years ago. All right. Now, we were actually kind of, I suppose, chosen. They came to us, and they had Choosing Wisely had 2 initial presenters. And at first, there was a ton of skepticism. After all, we're at a community health center serving Southeast Connecticut. We have a large number of patients. We do a lot of different things, whether it's obviously primary care, pediatrics, I do hospice, I do pain medicine, we do a lot of different things. We have a large behavioral health, we have psychiatry, we have dentistry. So a lot of people come to us with programs, with things they want to do. And so initially there's a lot of skepticism. Why? Because we're inundated with requests for education. We're inundated with requests for, can we study some of your patients? Can we participate in that? And so we understand that in some cases, what sounds good actually doesn't pan out. We've had a lot of presentations before. And the skepticism, again, was that most of these things, at the end of the day, maybe they don't change patient care. Maybe they sound like they do, but maybe they don't. And honestly, as a medical director, the last one on this page is kind of mine. Maybe it's just one more thing I'm going to have to do before I get to go home. And that was what I was thinking when I first walked into this with the initial presenters. Let's see. Oh, there we go. The presentation that we had about 3 years ago was excellent. They let us know, first of all, that they understood our burden. And I'll be honest with you, not all presenters of various programs, et cetera, do a very good job of doing that. As a clinician, they know I'm already busy. And they know, honestly, I'm probably working about as fast as I can. I think I work any faster, I'm going to start, how do I say this, providing poor care and maybe missing things. They let us know right away that this was not a bureaucratic paperwork thing, that this wasn't a thing where forms would be filled out, surveys would be done, data would be collected, data would be analyzed, data would be reanalyzed. It wasn't that at all. This was something that was designed to help us and to do it simply. And what really sold me was this. They let me know that this was allowing providers to have a means to reduce pill burden, testing, and necessary imaging. We're just like every other place, probably in the United States. We have a lot of people on a lot of different things. We have a lot of people that are on medications that are probably hurting them, too many side effects, a lot of unnecessary imaging. And I call it unnecessary when you get the imaging and despite what the results are, positive or negative, nothing changes. A lot of testing can be said that way as well. A lot of them were always being done under the, quote, just to see, end quote. And that was fine, but, you know, there was a part of me that understood that just to see, if it doesn't change what you're going to do, well, why are we doing it? And so that's what really intrigued me initially. All right. Now, so what happened is the presenters told us this. What we're going to do is we're going to give you some brochures. We're going to give you some posters, and we want you to initially talk about some of the key aspects of choosing wisely. Does this procedure need to be done? Does this testing need to be done? Is it going to change behavior? Is the risk worth the benefits? Is the cost worth the benefits? What surprised me was this, and I thought this wouldn't make any difference at all. What surprised me is that the posters were a big deal. I guess they were professionally done. I guess they look great. But I had so many patients when we had the posters in the waiting room, excuse me, and even in some of the patient rooms. They seem to be the key. These posters, what they would do is they provided a means because they were very simple and just went over those concepts, just like I said. And they gave, I think, the patients the opportunity and, how would I say it, the permission to start having a different kind of discussion. And what I found out was that discussion for so many people was pent up inside. They really wanted to have this discussion for a long time. I think many of them understood that maybe their pills were making them ill. But those posters, I guess they looked official. They gave backup to our claims of over-testing and over-prescribing. It already started that somewhat in earnest. And I had some patients who believed. I had others who didn't. I had a couple of providers who seemed to believe, but I had many providers who didn't seem to believe. But those posters seemed to start changing the nature, the tone, and the content of the conversation. I thought the handouts might be key, and the handouts kind of were a reminder, but the handouts didn't seem to make as big a difference. So it really became the fact that this seemed to be, through those posters, that low-tech thing that I thought wouldn't make any difference at all seemed to be the key to start changing the atmosphere at our clinic system. Okay, so we were asked to try this for a couple weeks. Again, more skepticism, especially among, well, I say myself, and among some of the providers as well. We did this at one site, and this is one site out of, we have 15 or 16, but we have only 3 major medical sites. More skepticism. We thought that patients like their medications. After all, they come here for that, don't they? And they want to feel better. They seem to ask for them. And when they don't have their medications, I thought, well, they seem to ask for refills. And to me, that seemed proof enough that they like their medications. And we thought that they liked their imaging. A lot of patients would say, gosh, you know, I want to know what's going on. Can you not take a picture of this and see? Sometimes it was their back or their neck, etc. And one of the things we worried about is we didn't want to be perceived as somebody who is starting to, how do I say this, deny care, to take away care from them, and thus to alienate their patients. That was actually a big concern. We thought we might actually have a bit of a mini revolt, at least among some patients. The feedback was actually very surprising. As I said, they read the posters. That became apparent on the first day. They read those posters. They asked me about it. And then the questions came. What I found out was all the assumptions that I had known for many years. I have been a physician for many years, maybe too many. But anyhow, many that I thought were happy as a clan believed themselves to be over-medicated. They did not want to say anything. That poster, again, gave them a legitimate platform on which to ask. Some surprised me, some didn't. And I don't mind telling you, on the other extreme, there were times where there were patients that I thought were perhaps over-medicated and was a problem, that it gave me the reason to ask, that I suspected that they were having the side effect of the medication, and they were slow to accept that, perhaps wanting a more, quote, physical, end quote, diagnosis given for it. And so at times it gave me permission as well. Many also felt that they were over-tested. That surprised me as well. I was used to hearing the fact that, hey, these people, don't they want to, quote, know what's going on, end quote? And I found that not all the time. Especially, they were much more astute than I thought. What a lot of the patients realized is they would get a little information, but it wouldn't change anything. And then they would look back and say, then why is that doctor getting that information in the first place? I started to find out that my patients were a little bit smarter than I thought they were. That perhaps I shouldn't be so condescending, that perhaps I shouldn't be so arrogant, that perhaps I honestly ought to listen to these folks. That really changed the way I practiced medicine even after all these years. All right. Once we did this, we had positive feedback from the initial group. Everybody thought it was a good idea, and I was, again, a little surprised. Sure, were some more than others? Yes. But at the same time, overall, people thought that this was a good thing. Bringing it to the entire system, though, would be even more daunting. We had lots of different kinds of providers in lots of different places. We have one that's kind of more like it's a small city, but there's an inner city aspect to it. We have some, though, that are pretty much in the countryside, and then we have some that are kind of mixed suburban. We also have older providers, very young providers from very different backgrounds. We worried that, well, is this going to fly with everybody, or am I going to have, a group of people that are going to, put their foot down and say, you know what, maybe enough's enough here. We knew it'd be more challenging, and we knew that there might be certain groups of people that might be more inherently resistant to it. Perhaps there are people that have been in practice for a long time who just simply decided that they knew what to do, and that any evidence to the contrary needs to be discarded. We also, again, knew about the different perspectives. And yes, at times I did have some overt skepticism. I had some people saying that was not a good use of our time, that we need to be doing something else, that this is one of those programs that are simply going to go away. And I also had to deal with that a little bit. But at the same time, I simply asked for time, I asked for patience, I asked for understanding, and I tried to give some compelling and logical reasons about why this might be the program for them. And it's not illogical. It's actually using logic. It's using those cognitive skills that we have, and it's actually applying them maybe to the next level. With that, I was able to get a lot of them back. All right. All right, strategy. First thing I have to do is I have to introduce the concept. As I got to a broader group of people, I had understood that not everybody had even heard of choosing wisely. I had devoted some meeting time to it. We meet once a month in general. I had to make sure that a significant portion of that meeting time was about choosing wisely. Why? Because the group understood that the more time was spent with it, especially at the initial meeting, the more important we thought it was. I mentioned in passing, it wasn't going to work. If I gave it 3 minutes, it wasn't going to work. But if I spent most of my meeting time and say, hey, this matters, and this matters so much that I'm willing to talk with you about this extensively, that honestly is crystal clear that this is an important thing. What did I emphasize? The first thing I need to emphasize is how it's going to make your life easier. There's going to be less overall prescribing, hopefully. Less testing, less refills, less follow-up. And what I mean by that, not that you shouldn't have it, but less mindless follow-up. Follow-up just because you say a month and you say a month to everybody. And hopefully we can have some friendlier patient outcomes. At times we have patients that seem very antagonistic to our whole process. They seem frustrated. Oftentimes it's because they felt that they are not heard. Well, sometimes it's other things as well. But that was actually one of the more common complaints. We were hoping that through this system, maybe we could find a different way. One of the things that we noticed, though, is that some of the issues that we have with this was we thought that people were going to say there's not enough time. You're going to make my appointments impossibly long, and this isn't going to work out for that reason. I was worried about that, even though in the initial I told her that did not seem to happen. The conversation seemed to be different, but not longer. And because of a little bit less testing, we had actually more time. So I introduced the concept big time. I didn't want to appear to be shoving it down people's throats. So for the next 30 days, I did nothing. I told them, I said, we're going to implement this, but we're going to take a little time. I asked them to look it up on the website, let them know it's through the American Board of Internal Medicine. But at the same time, I wanted people to have an opportunity to ask me questions during the month. I wanted them to be able to wrap their brain around it, and not that we're seizing the moment and presenting it one day and making you do it the next. And so at least for our group, I don't know about groups nationwide, but for our group, I think that worked. I think that paid off. I think that I went a little slower than usual. I think may have been a good thing. All right. So then what I did is I represented the material in a slightly different way. Hopefully I had some support that maybe things can be easier, and that's one thing. But I have a lot of people, like everywhere. Everybody wants to do a good job. Excuse me. We don't get into this line of work in order to do a haphazard job, in order to leave our patients half-treated, inadequately treated, or anything of the nature. We want to do the best we can and really help these folks. That's why we're there, and especially working at a community health center. We're not the most prestigious place in the history of the world. We understand that. And mainly we have people who have decided they want to work in a place where they make a difference, as opposed to a place where maybe the salary's better or the title's a bit more prestigious. But what I wanted to do is I wanted them to let them know that this is also a scientifically based thing. And that's where I had to have some, some education here. I told them about being more, quote, scientific, unquote. And what I meant by that is that this is protocol driven. All we're doing is following the protocols of all the major medical organizations. But what we're not doing is doing things that are simply not in the protocol, and maybe not in the protocol for good reason. Therefore, it's more evidence-based. And again, it's more protocol-driven. It's what we're supposed to be doing. I showed specific examples of how doing this can actually help patient care. Now, there's some that are more famous than others, and the PSA, the prostatic specific antigen, is a classic case. As many of you know, in the 80s and 90s and maybe into the early 2000s, checking a yearly PSA in a man over 50 years old was considered the norm. We're screening for cancer. Don't you want to screen for cancer? Don't you care about the lives of these men? Of course you do. You're going to do it. The trouble is, in these cases, it became quite obvious that we were over-screening. A number that was slightly higher than what it should be, 4 was usually the level, 4 nanograms per milliliter, I believe, would send you off to the urologist where perhaps a biopsy would be done. The trouble is the vast majority of those were indeed negative. There are oftentimes were complications like from the biopsy, like impotence, incontinence, and even some serious infections, etc. And what had happened is we studied, it became very apparent that very few lives were being saved, and perhaps even lives were being lost because of it. That screening everyone indiscriminately every single year, all the time, was simply not the way to go. But unfortunately for some, that persists. Many would tell you that they're afraid of getting sued, when in actuality, liability may be on the other side. If you're doing these screens willy-nilly and you're sending people off for dangerous biopsies, perhaps there's something there as well. But that was one of the examples that I gave, trying to show how a more reasoned approach, a more logical approach may be a more efficient approach, and is kind of what we're thinking about with choosing wisely. All right. I also added the medical legal aspect. Again, I said more is not better. In fact, more can lead to worse outcomes and potential litigation. Obviously, the PSA, that's an easy one, but that's one to get started. The best way to avoid litigation is to do the protocols, is to know the protocols and apply the protocols. If you do that, and you can say in a court of law, hey, at this time, the protocol was for low back pain, step 1, step 2, step 3, step 4, and not an MRI in the first visit, you're going to be better off. If it looks like you're straying from the protocols, whether you think you're being extra careful or not, it does look like you can be a sloppy physician. Maybe you think your way is somehow magically the better way. one might be able to take that reasoning too far, but at the same time, I had a house full of providers that were doing just that. They were doing all kinds of things to just see, to just be sure. Well, you never know. Well, I don't want a lawyer knocking on my door. Were actually one of the more common things that I used to hear. But I also used to think that a lot of those comments, while designed to kind of shut down debate and shut down thinking, were honestly without a lot of merit. All right. Let's see, the next slide. But the core concepts we wanted to give to the providers is this. I can make your job more fun. I can make you partnership with patients by having this honest conversation. Instead of talking down to them, instead of talking almost over their head, instead of telling them how it's going to be. Wouldn't it be nicer to actually get to know these people? Wouldn't it be nicer to have a one-on-one conversation? Almost at an equal level. They know some things about their life. You know some things about the protocols, about what you're supposed to do, coming together. It might be a nicer way to practice medicine. Maybe a more relaxed way as well. And then I emphasize some of the things I've already gone through. Let's practice better medicine, not just more medicine, not defensive medicine, not medicine that you're convinced you're going to be sued even though you haven't after 30 years on that particular thing. I was quick to point out in this case that choosing wisely is from the American Board of Internal Medicine. I did have one or two people suggest early on that perhaps this was from some kind of economic group that really pushed this in order to keep down costs. Well, I don't want to tell you costs might be kept down. At the same time, all of these protocols that we follow that are given to us in the Choosing Wisely website, frankly, are for medical organizations. It's not an economic council deciding things at all. And because of following the protocol so strictly, so well, and knowing them and being familiar with them now, and there's actually less litigation, I believe, could be there. I can't prove that one. Unfortunately, we have not been a big target of that. But at the same time, the best way to avoid that, I believe, is to follow those protocols. And also the patients prefer this method. They seem to open up. They seem to relax. They're being heard a little bit more. So once we got it going, what we had to do is to normalize it, make it a part of everyday life. Okay? So it's one thing to introduce it. It's another thing to put up posters. But old habits die hard. After all, here I am, a physician, I will say, of considerable experience, you might say, and I'm now being asked to do things quite different than what I used to do. That's not easy to do, and it's easy to start going back to old tricks and old ways of doing things and going back to things that, frankly, on many levels did work before. So what we would do is we would go over 3 or 4 concepts from the website that might be most relevant for our patient population. We would start with things that are fairly obvious, okay, that most people had heard about. Most people understood that everyone who comes in with a backache, which is so ubiquitous today, they don't need an x-ray necessarily. Oh, sure, if they have some red flags, so to speak, some direct trauma, other issues, they might. But for the people who come in with simple lumbago, no radiation, no red flags at all, an x-ray at the first visit isn't necessarily the answer. Then we would discuss newer ideas. Okay, what is a treatment protocol for low back pain? What does work? What doesn't work? And what we found is people were very surprised. Some of the things they thought would work, actually the literature showed maybe it doesn't. Other things they thought, no, that would never work, maybe it does. For instance, we tend to over-rely on muscle relaxers. They probably help a little bit, but to sit there and say there's some kind of panacea for all back pain, that's simply not the case, and the literature bears that out. Surprisingly, acupuncture, for instance, might work well. Actually, there's some recent literature that says maybe it doesn't. So there's surprises that were there that we all could learn from. And this opened that gate to start talking about that. So what we did is that the key seemed to be consistency. We want to normalize it. It's got to be there every month. Not a lot of time was spent on it, but we're going to spend a few minutes talking about 1 or 2 concepts. And then it became kind of known that if you want to be the superstar provider, the person who does things right, it is not now the person who orders the most tests. One thing I will say when I came to UCFS 5 years ago is that very much was considered to be the person with the best care. the one who had the most pills at the end of the day and the one that had the most tests done. Now, that was never said, but it sure as heck was implied at almost every level. If I'd ask him about care for the patient, I would get a laundry list of pills, and I would get a laundry list of tests that had already been done. That wasn't the same as good care. It took me a couple years to get that across to people, but that's not what I'm looking for. I'm not looking for 10 trials of medications. I'm not looking for the most obscure test. I'm looking for the best care, not the same thing. All right, let's see, moving on. So we had to reinforce choosing wisely. We're a community health center. We're required by the federal government to do certain things like chart reviews. And that provided an opportunity as well. So again, on chart reviews, since I have to do them anyway, I didn't use choosing wisely in name on the chart reviews, but in spirit. We started evaluating the appropriateness of labs, not just if labs were done. The appropriateness of radiology, not just if radiology was done. Sometimes it is appropriate that those things are done, other times not so much. And that avoiding polypharmacy, especially if there were some, pathognomonic medications and side effects. For instance, we had people that were on amlodipine at 10 milligrams a day. For the physicians out there, that can cause some swelling. So if the diagnosis the next 3 months was pedal edema, one of the things that we would certainly ask in a chart review, have you ever considered the medication may be the cause of the pedal edema? Well, of course it could be heart failure and venous issues, other renal insufficiency and other things. It has to be in the differential. When we'd ask on chart review is, was it in the differential? Did you at least think about it? Could it be there? We don't want to necessarily say that all pedal edema is always due to Norvasc. But we also don't want to say that that can never happen. Unfortunately, we were to the second mindset that the medication could play no role when I first came, as opposed to the first mindset that it needs to be in the differential. All right. Now, we really tried there to create a culture of choosing wisely. And when we looked at the chart reviews, what did we find? We found personally, now this may not be necessarily, everywhere all across the country. Every group may have a different problem. But I can only tell you what we found at ECFS. We found over-testing, labs being endlessly repeated. We were big into getting A1Cs for diabetics. And there's nothing wrong with that. I mean, that predicts morbidity and mortality. We were sometimes getting it every month on people, just to make sure we got them, so to speak. And so, as people probably know, the pathophysiology of the A1Cs, getting them before every 3 months really doesn't make that much sense. These were well-intentioned, well-minded people actually trying to be thorough in doing their job. But that was one of the small areas that we actually improved on, is that, yes, we want to make sure everybody gets in 3 months. But please, not every visit all the time, especially when we're in that maybe acute phase of adjusting insulin every couple of weeks. We have medications that only seemingly made sense. Now, for instance, we might have fibromyalgia pills that were still being given, despite the fact that they made no difference in pain, tightness, etc. whatsoever. IBS medications, same thing. Some of those things should have been therapeutic trials. What had happened in many cases, those things actually didn't work for that patient for whatever reason. Excuse me. Now, a reasonable thing to do, especially in those two cases, if they're not making a difference in any way, shape, or form, they should be discontinued. But they weren't, because after all, they were part of a treatment option protocol that might be there for irritable bowel or for fibromyalgia, but not for that patient. And that's what we try to do, is they seemingly make sense, but they don't work for that patient. And this would be an example where we're trying to treat pain and or discomfort. If they truly don't work, please don't continue them. A couple of typos there, but we were also far too quick to order radiology. The back pain thing was a big part of it. When asked, I think the number one reason was that the patient felt that things were being done if I ordered an x-ray. We had to change that line of thinking, and that was very difficult to do. What we try to do is that we provide a lot of education on what we can do for back pain to make it seem like, and to truly be this way, not just to make it seem like, that's a terrible choice of words, that we are engaging the patients and doing the things that we need to do for simple lumbago. For instance, we would show them comprehensively a series of stretches that they could do if we thought it was muscle in nature. We would show them, we would give them examples of how they can get towards, for instance, back to work, other modalities that might work, physical therapy, other types of manipulations that might be helpful, and that when x-rays might be needed. We would provide a whole kind of educational framework. We would let them know what medicines might be helpful versus what medicines might not be helpful. So they felt like they got a lot of information, and they did get a lot of information. But what we tried to emphasize, not a back x-ray, not for simple lumbago, no red flags whatsoever. That was our deal. All right. And we also found that sometimes we would use outdated treatment protocols, commonly no protocol at all. Meaning, an example, maybe using the PSA indiscriminately. I saw that there was a question there about African Americans. Obviously, with all the protocols, there are, how would I say this, high-risk groups, and that's part of the protocol of medicines, is that we have to use high-risk groups. But we were having people that were using simple screening things from 10, 20 years ago and applying them today, and they simply were out of date. So that, how do I say this? So that absolutely was an issue as well. Overall, what we found is that a lot of providers were sleepwalking through the day based on what they thought was right and based on not what the current science was. But in a way, it was exciting. It was great because we got to learn together. We got to learn a lot of new medicine and become better at our jobs. And that's where that culture change was. And that's what excited me about this whole thing. This allowed me the avenue to get that going. All right. Again, one of the things I cannot emphasize, when I came here, it was more is better. If my guy's on 10 pills, I'm doing a better job at treating my guy than your guy who's only on 3 pills. And we gave providers the way to change that thought process, that better care is better care, more care is not better care. Sometimes, yes, it's got to be a lot. Sometimes we need to be minimalist. Every situation is a little bit different, but we need to use our brains and our training. And that's one of the things that also was exciting. I'm letting them they're using their judgment in this. They're using a little bit more insight in this. And it makes, I think, the treatment and the practice of medicine much more exciting than to sleepwalk through. Well, let's say your elbow hurts, I'll get an x-ray. Your wrist hurts, I'll get an x-ray. And your finger hurts, and I'll get an x-ray of that too, without truly thinking, do I need an x-ray that's going to change what I do? Or what is truly my differential on this? Is there something there? Is this obvious venous epicondylitis, for instance, for the elbow, which would not necessarily require an x-ray on the first visit? Things like that, where now, no, I'm starting to think, I'm starting to use that training, and I'm starting to become better for it. All right. What we did to help with this culture, we asked our providers to very briefly, and we tried very briefly. They got a lot to type. We have a system that, I would say, it's not the most efficient. Like an EMR, it's not the most efficient in the history of the planet. I won't say which one it is, but suffice to say, it's not terrible, but at the same time, it's not the most efficient. But we said, could you just very briefly provide a rationale of what you're doing, maybe a differential diagnosis of just maybe top 2 or 3. It had the patients, the providers, get away from the automaticity, provide a rationale of what they were doing, and justify that as well. It woke them up a little bit. It made them think just a little bit more. And especially when they need the chart review, they're going to be reading that. And one of the huge things that we would be looking for in chart review is, does that rationale make sense? Is it coherent? We didn't see the patient in chart review, and we know that, but at the same time, looking back, does that make logical sense based on the information in front of us? It allowed and had the providers start that thought process. And again, the best managed charts and the most coherent, logical charts start to become the best charts. All right, so we pointed out the following. Some of these things have already been said. You may be hurting your patients with polypharmacy. Tough one to swallow. Nobody likes to hurt people. But again, the very simple one about the amlodipine at 10 milligrams a day, you have to at least consider that might be you. It might not, don't get me wrong. And we tell people for serious things like that, you need to do appropriate work. That needs to be in your differential. Okay? Once they started looking for it, they found it everywhere. Common things were lots of blood pressure medicines all at the same time, hypertension. Diabetes medicines that cause hypoglycemia. Excuse me. Psychiatric medicines were a big one as well. 3 or 4 psychiatric medicines trying to do the same thing. The serotonin receptors can be only, stimulated and modified perhaps so many times. Another common one as well. We found that you may be exposing to needless labs, and again, the main thing that we were looking at is this going to change what you're going to do? If it does, fine, but if not, don't. We also talked about radiation. One of my patients, when I came here, had about 20 CAT scans of the abdomen for chronic pancreatitis over 4 years. At times, she would beg the ER physicians, this is mainly ER, I will say it's not us, to not do it, but they wanted to, quote, just to see. I think they were looking probably for pseudocysts, which I understand, but they would not necessarily want to miss. But if they had a CAT scan 2 weeks ago, the chances of the pseudocyst being there with only a very slightly elevated lipase, I think, would be fairly remote. And actually, that patient can be watched anyway before exposing them to needless radiation. At some point, the radiation becomes the issue as opposed to the unlikely presentation of a pseudocyst over 2 weeks that would be found if the patients continue to have symptoms at any rate. We had to change that. We had to we actually let the ER know, but we also changed our thinking as well. That matters. Radiation matters. That can't be completely discarded. Now, at times it can't be the most important thing in the room, but at times it does matter. So taking CAT scans to, quote, look and see without having any idea what your specific diagnosis or what you're looking for may not be what you need. Okay? And then procedures. Some procedures may be pointless. One of the things that we looked at quite a bit was epidurals. If a patient's already had epidurals for low back pain and they are sent by another physician for epidurals, the epidurals didn't work the first time, the patient has the same back, it's the same patient, the epidurals will probably not work the second time as well. What are you doing here? Let's start thinking. It didn't work, it's probably not going to work again. And keep in mind for the, like for instance for epidural, there's very specific indications on back pain and very specific disorders in which it can work. And there are other disorders where you think it would work, like just degenerative disc disease, where it probably doesn't work, we don't think. So it's one of those things. Think about what you're doing. Obviously, this doesn't apply for all procedures all the time. Some procedures are simply life-saving. I'm not saying that they don't need a cardiac cath as they are having a ST segment elevation MI. Not trying to imply that at all. All right. The results. Now, one of the things that I didn't get to do is this. I'm the medical director at a busy place. I would love to give you a graph after graph after graph of the data that we have that proves that we have all these things. I can tell you they're true. You may have to believe me. Maybe that's a flaw in the system. It is. But at the same time, there's only one of me, and there's only 24 hours in a day. What I know that we have is less polypharmacy, antibiotic use, low back x-rays, PSAs, in low-risk people, of course. Over-repetitive lipid panels, man, we were getting some every 2 months. Maybe after initial therapy, you can justify something like that, but over and over and over again, the same patient, the same diet, the same pills, probably not necessary. And then radiation exposure from CTs, I was glad to see that go down. We just had to think about what we're doing and what disease process we're looking for specifically. All right, what we found is that we have more informed discussion with the patients. I actually get along with patients now better than I did 3 years ago. Shared decision-making is up, definitely, and we go over risk and benefits with patients in almost everything that we do. Patient satisfaction seems to be very high as well. And I love the fact that I'm actually practicing rational and not defensive medical decision-making. It makes my job, like I said, a heck of a lot more fun. Interestingly, this didn't take more time. What we found is that we were chasing down less and less labs and things like that, and we were spending more time talking with the patient. So we invested time, and then we saved time on the back end. My burden was about the same. All right, let's see. Conclusion. Choosing wisely maybe best describes a way of thinking, getting away from automaticity, getting away from defensive medicine, avoiding cognitive traps and errors. That seemed like the thing to do. I don't want the lawyer to come. Let's take a look and see. Instead, it's think about what you're doing. Look at risk and benefits, not just benefits. Involve the patient. And like I said, one of the things that's very humbling to me, these people are smarter than you think. They're not stupid. They know when tests don't matter. They know when labs don't matter. They know when they're being pushed around, and they know when they're being sent from one place to another needlessly. It made me read. I had to look up guidelines. Choosing Wisely has it on their website. It's not very well organized. I'm not going to lie to you, but it's there. And you want to become that provider who provides insightful and thoughtful care, and not just more care. And I believe that's all I have. Questions, comments, bring them on.
Super. Well, thanks so much, Chris. That was quite a journey through your journey. So thank you so much. It was really fascinating. We did get several questions and comments in the chat section, and I'll also encourage people to unmute your phones if you want to jump in with questions. But just to start with those that have already been sent in. George Podoworski asked that the poster explicitly explain what over-medication is and encourage patients to ask about over-medication. Kelly shared the Choosing Wisely poster, which is really the 5 questions, so it doesn't specifically ask about or comment on over-medication, but I just wanted to raise that in terms of, did you have other thoughts about that in terms of building off the 5 questions?
That definitely was a building off the 5 questions. I'll be honest with you, in implementing this is a little selfish on my part. I used that as an excuse to go after some of the people who were probably over-medicating, including on narcotics. Over-medicating can be defined in many ways, and I'll be honest with you, there are times, I don't mind telling you, where good, strong clinicians can disagree with each other, whether a person is being over-medicated. That does happen. I know a lot of geriatricians would say, hey, if you have somebody who's on over 8 medicines, you need to at least take a look at what they're taking and maybe look and see. I guess what I would say is over-medication is when you have medications that are beginning to cause more harm in the realm of side effects than good, and that tend to be, additive for very little benefit. Again, maybe where the risks start outweighing the benefits. Subjective, somewhat to be sure. Relevant, though, and does it happen? Of course. Sometimes the risks do outweigh the benefits.
Okay. And then regarding the first part of your talk where you were talking about letting the message sit for a while, you said you sort of, let it sit for 30 days. We had another question. Were you trying to, with that 30 days, were you trying to reinforce your logistically framed message from 30 days ago, or were you trying to appeal to those physicians who were swayed by science? Trying to understand the rationale or strategy behind the 2-step messaging, your 2-step approach, and its generalizability.
Okay, so what I was trying to do is this, and I don't want to sound ageist right now because I'm on the older side myself, but I had a couple of physicians who felt like they have seen everything, done everything, and this is going to die too. They felt like that it added no benefit, and I guess as far as they're concerned, they're providing perfect medicine in every conceivable way. It took me a while to talk to them, to wear them down a bit, to get it comfortable. So honestly, some of the 30 days I was kind of campaigning them, or at least asking for their patience and perseverance in this, and for others just having them get the idea used to it. So there was a bit of campaigning for my most resistant physicians, especially when I felt that they were being resistant for personality reasons and not truly professional reasons.
Okay. Then regarding the specific test from Jennifer Birch, when you decided to cut back on PSA testing, did you continue to test high-risk populations such as African-American men or those with a family history? Did you engage in shared decision-making with those who might be high-risk concerning whether those men might want to be tested?
The answer is absolutely. In the protocols, in the guidelines that are there, absolutely, those are there. 45 to 49 African-Americans, absolutely. High risk, absolutely. Shared decision-making is in all of the guidelines for PSAs. So that is a wonderful example of, yes, would those people still be done? Yes. Would those questions still be asked? Yes. But would it be more targeted? Yes. And would it be less automatic? Yes. The 52-year-old who has no family history, no symptoms, is not African-American. Well, maybe not. Well, I would certainly still talk to them about that, at the same time understanding that the risk and benefits of where they are at with that. So the answer is yes, the high risk. That's a great thing about this. Yes, the high risk will still be there. And yes, the shared decision making is still there, but taking the automaticity off of it for the very low risk and not hurt them while I still protect the high risk.
Super. Okay. And then one more from George. So George, if you can unmute, I'm not sure I totally understand this question. Did the request for a rationale was the request for a rationale well received versus being seen as one more thing or questioning professional autonomy?
It was sorry. It was the request. Yeah.
Okay.
So you yourself earlier on, Chris, in your talk, the skepticism, and this is a typical one, is are you just asking us to do more stuff? And I see the request for a rationale as potentially not just interpreted that way, but potentially, if someone's going to be looking over my shoulder, and that may be interpreted as, questioning their professional autonomy or a threat to their professional autonomy if they're going to be accountable.
Okay, so that's a great question. That's a darn good question. And the most honest answer I can give you in this culture here, because we have to do chart review and we are at a community health center with a hierarchy, a medical director, a chief medical officer, et cetera, they know to a certain extent their charts will be looked at. And so what I wanted to let them know is that this is where medicine is going. Now, I had to do that in a way, this was tough, in a way where I'm not being condescending to them, in a way where, how do I say it, that it doesn't mean that I think that they're always practicing bad medicine all of the time. But at the same time is that yeah, your charts are going to be looked at from time to time. This is what we're looking for. This is the, the rules of the game. Now, I understand that in other situations, in other work situations, the physician or physician assistant or practitioner may have full autonomy and no one ever looks at anything. In a way, I had it easier because, no, the culture was already there, is that your charts are going to be looked at. They just are. They're not going to be, completely and utterly and always second guessed, because if that happens, then no one's going to want to work here. But at the same time, I had a built-in advantage that, frankly, yeah, they're going to be looked at. Here are the rules. I'm telling you what the rules are right now to a large extent.
Great. Okay.
Thank you.
Others, feel free to unmute and jump in with any questions. Well, I have one, Chris, and apologies if you said this if I missed it, but do you have, how many sites do you have of your practice?
Okay, we have 3 major medical sites at our practice. We also have counselors that are at 12 or 15 others, but 3 major medical sites. And we see, 75,000 people a year, employing about 20 to 22 different medical providers, almost all full-time. Is kind of how we do it, somewhere around there. Those numbers are approximate, but that's pretty close.
Great. So I was just wondering, how has this spread? And again, maybe you said that in your initial comments, but have you focused primarily on your primary site, or how have you really spread this across the other sites?
By having those meetings where we're all together, okay, that was the key. And so from those provider meetings where everybody's in the same room, I am speaking to them and setting the culture, and then having them bring it back out. And then emphasizing that when we either do chart review, when we do any kind of meetings together, when we have any other issues about talking with about particular cases, we're very much going to go into the realm of choosing why did this need to be done, did that need to be done, why did it need to be done, and what do you plan to do about it. So when they ask, for instance, when they ask me questions, that's going to be the first thing that comes up wherever site we're on. I do go to all 3 sites. So in that way, I'm able to continue to spread the word that, hey, this is the kind of the thinking that we're looking at to become more effective, more efficient, and frankly, just better at our jobs than before.
Great. Okay. Thank you. Anyone else with questions?
May I say something in closing then?
I'm sorry, you're just a little bit broken up on my mic. Can you say that again?
May I say something in closing?
Absolutely.
You can tell this is I love this program. It's a great program. I think this has changed practice for us more than anything that we've ever seen, whether it's patient-centered medical home, PTN, or any other governmental acronym that you can probably think of over the past 20 years. Because it truly is different. It truly is revolutionary. It truly is where it needs to be going, where as far as medicine needs to be going, to be both more fulfilling for the patient and the provider. It's no extra work. It's a different way of doing things. You get to know these patients better, and frankly, I've gotten to respect them a lot more.
Holy cow. That's quite an endorsement. Thank you so much.
No problem.
That's one of the strongest supportive statements I've heard. So thank you for your work, and thanks so much for sharing it today.
Not a problem. Everybody, thank you for listening.
All right. Well, if we don't have other questions, we will wrap up with a giant thank you again. And Kelly, shall we pass it back to you?
Yeah, I just want to thank you for moderating and thank Dr. Kolker for his presentation and your enthusiasm and commitment to choosing wisely, and everybody for attending today. Again, we will have the recording available for anybody you'd like to share it with. And thanks for joining us, and have a great day.
Thank you.
Thanks all.
Thank you.
Thank you, Chris.
Bye-bye.
Bye-bye.